السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله وعلى آله وصحبه ومن والاه. I would like to welcome you to the second session for today's scientific activity. My name is Walid Hafid. I'm a rheumatologist from Mecca and interested in scleroderma. I would like to thank and congratulate the Saudi Society for Rheumatology and the Saudi Thoracic Society for the continued success and progress of this meeting. We remember that 2 years ago we met and we had the first master class, and today we're meeting for the third master class, and we're looking for the 10th master class inshallah in the near future. And if you can see that the color was chosen beautifully and on purpose, so we all know that purple is the color for lupus, and the navy blue is the color for scleroderma, by the way. That's the international. And one other information that this month, June, is actually the month for scleroderma. So the world celebrates the World Scleroderma Day on June 29th, and this was also made on purpose. So the choice of the date was made on purpose. So I'll be chairing this session along with my colleague Dr. Nizar Bakhsh. Dr. Nizar Bakhsh is a consultant rheumatologist at King Salman Hospital here in Riyadh. He has obtained his clinical fellowship scleroderma from the University of Toronto in Canada. So the theme of this session will be covering interstitial lung disease in patients with systemic sclerosis slash connective tissue disease. And the first speaker for this session is a dear colleague and friend, Dr. 1abduallah saqat, who I really enjoy sharing a workshop with CTD-ILD management. Dr. 1abduallah comes from the West Coast, from Jeddah, and he is a consultant pulmonologist and an ILD expert, and he's also an assistant professor of internal medicine and pulmonology at King Abdulaziz University, Jeddah. Dr. 1abduallah saqat will be sharing with us the first session that is entitled SSC ILD prevalence as well as screening. The floor is yours.
Thank you so much, Walid, and thank you for the organizing committee. It's a pleasure to be here today. Right. Bismillah ar-Rahman ar-Rahim. So today I will be talking about scleroderma, ILD, and specifically the outline of my talk is to talk about the prevalence of systemic sclerosis ILD, which patients are at risk of developing ILD, and of those patients who had ILD, which one is most likely to progress. And then we're going to talk about the outcomes, and then I'll conclude my talk with the screening for scleroderma ILD. Scleroderma ILD prevalence. As you mentioned from Dr. Hanan in her introduction, initially that postmortem analysis of patients with scleroderma, up to 100% will have lung involvement in any of kind. So in this slide, there's some, So if you look at the studies, the variation is variable. And that's probably because of many factors. The first thing, what did we use to diagnose the patient? Is it chest X-ray? Is it HRCT or is it PFT? And the second thing is which patient population you're looking at. Are you looking at diffuse patients or are you looking at more limited patients? And lastly, the geographic locations. So this slide summarizes the prevalence rate of systemic sclerosis ILD in different countries of the world. So if you see in Canada and US, the average is around 47%. In Europe, it's less, around 35%. And in East Asia, is around 50%. And if you look at the Netherlands, so if they have 19% if you look at systemic sclerosis ILD using PFT, but if you look at them using HRCT, you're going to have more patients, around 47%. So what you can conclude from this study is that ILD involvement in systemic sclerosis is very, very common. So which patients are most likely to develop ILD? So you have a patient in the clinic, which one is most likely to develop ILD? So we can divide them into demographic. So if they are male, they are African American, and disease related, so diffuse cutaneous disease or they have a cardiac involvement. And some serum markers can help us, like anti-CL70, absence of anti-centromere antibodies, or if you have high CK. All of those factors are risk for developing interstitial lung disease. So your patient had ILD, which one of them you need to pay attention to, treat aggressively. Those are the patients who are likely to progress. And those are the features, the risk factors for those patients. So again, demographic, male, older age, African American, disease related. So if they have short disease duration, so recently diagnosed, they have diffuse systemic sclerosis, GERD, and as we saw from the previous talk, how GERD is important as a complication and as it's associated with worse disease progression. And then we have physiological factors like low baseline forced vital capacity, low baseline DLCO. And if you have extensive disease in your HRCT, more than 20%, and some serum markers like positive antiscleroderma, absence of anti-centromere antibodies, or if you have elevated acute phase reactant CRP. So what's the outcomes of systemic sclerosis ILD? So this slide summarizes the outcomes, the cause of death for patients with systemic sclerosis from the 1970 to 2001. And as you can see in the pink column, which represents renal crisis, up to 1982, it was the most common cause of death in patients with systemic sclerosis. After the introduction of ACE inhibitors in scleroderma renal crisis and the significant reduction in mortality, we saw a trend in the leading cause of death is going to be as pulmonary causes, as pulmonary arterial hypertension and pulmonary fibrosis in the gray, the blue, and the red column. And more recently, analysis of the EU STAR data. So they found 6,000 patients with scleroderma, 284 deaths. Of those, 55% were attributed to systemic sclerosis. And as you can see, the most common cause of this was 35% ILD, 26% pulmonary arterial hypertension, followed by cardiac involvement. And we look at the data sets from different countries. So if you look at Canada, between 2008 to 2018, the survival rate at 1 year was 77 and at 10 years was 22. And when you look at the France registry, the 1 year survival was 92, and 8 years they did better than the Canadian group, 65%. And there is also a registry in Norway where they looked at only 2 years, and the 10-year survivals was 56%. How about outcomes from actual clinical trials? So clinical trials patients are the patients who are receiving treatment or placebo, but they have close follow-up. Those are the patients who are receiving the optimal care. And despite this, if you look at the SLS1 trial, the cyclophosphamide versus MMF, where they had 100% ILD patients with a median follow-up of 8 years, the mortality was high, 48% in the cyclophosphamide arm, placebo was 35%. And when we look at the SLS2 trial that looked at cyclophosphamide, SLS1 was, cyclophosphamide versus MMF, 100% ILD patients with a median follow-up of 3.6 years, and the mortality is around 22%. So SLS1 is supposed to be cyclo versus placebo. And then we have the stem cell transplant trials versus cyclophosphamide. Again, mortality around 17 to 28%. And also the ASTS trial, 24 to 30%. So despite aggressive early treatment of systemic sclerosis, we still have very, very high mortality for those patients. How about the morbidity? So looking at the lung function, that's the most commonly measured outcome in the scleroderma clinical trials for the lung. So if you look at the SLS1 trial, over 52 weeks, the reduction in lung function was around 2.6% predicted. And then in the census trial, this is one of the big trials in the scleroderma ILD. So over a 1 year also, the reduction was 94 ml. And then we have the DESIRE trial that looked at rituximab versus placebo, shorter duration, 24 weeks, and decline in lung function was around 2.8%. And then the last one was the FOCUS trial, where they looked at tislelizumab versus placebo over 48 weeks, and the annual reduction, almost annual reduction in forced vital capacity was 255 ml in the placebo arm. And you can see that there is a huge difference between the FOCUS trial and the comparison to the other trials. And the reason why is that the FOCUS trial include patients with active disease, diffuse, SCL70, high CRP. All of those are risk factor for progression. So if it tells you something, it tells you that you have to pay attention to the risk factor for your patients to identify patients who are likely to progress, and those patients will likely need early and aggressive treatment. So my patients has ILD, which one are most likely to die from the ILD? So if you have a patient who are elderly, male, African American, And as you can see, there isn't a big overlap between who is likely to develop ILD, who is likely to progress, and who is likely to have high mortality. And physiological factors, low baseline forced vital capacity, low baseline DLCO, and if they have decline in forced vital capacity and DLCO over time, and if they have severe disease in the HRCT, or if they have combined pulmonary fibrosis with emphysema, CPFE, and also systemic sclerosis related factors such as diffuse systemic sclerosis, anti-CL70, pulmonary hypertension, and biomarkers like elevated CCL18 and high CRP. So now we have established that our SSc-ILD is common, and it's a disease associated with very high mortality. And now we're trying to screen those patients. So just to make this more interactive, so we're gonna take a vote on this question. Would you screen all patients with systemic sclerosis for ILD at baseline? Option A is gonna be screen only symptomatic patients. Option B is screen only high-risk patients regardless of symptoms. C, screen all patients regardless of symptoms. Who would go with A? Everyone C? Okay, good. Mumtaz. So the second question in my talk, how would you screen systemic sclerosis patient for ILD at baseline? A, PFT, B, chest X-rays at baseline plus baseline PFT, or HRCT plus baseline HRCT? كله سي غششت. طيب المرة الجاية صعبة أخليها بي سي. طيب. So why it's important to screen systemic sclerosis ILD? For many reasons. Number one, it's common. Number two, it's a disease associated with very high mortality. And there is treatment options available. And we know from clinical trials that early treatment is associated with better outcomes. So when you are trying to screen a disease, you need to screen that, you need the disease that's common, which we have in systemic sclerosis. You need disease associated with high mortality. So there is a benefits from screening. We have that in systemic sclerosis ILD. And you need to find the best test for that. So the best test is going to be a test that's sensitive, specific, reproducible, and with less variations. So let's see the performance of the following interventions over the few slides. So are symptoms alone a good screening test for systemic sclerosis ILD? So this data is from the census trial. When they did the analysis of the census trial, so the census trial included all patients with systemic sclerosis, and one of the inclusion criteria, they must have ILD, at least 10% in the HRCT. And of those patients, 30% did not have any dyspnea. So you missed 30% if you rely only on symptoms. And even their function, even if their forced vital capacity was actually reduced and they did not have any dyspnea. So if the patient is not exerting him or herself, they're not going to have dyspnea. So as you saw, dyspnea is not a good screening tool because you're going to miss a significant number of your patients. And then moving to the PFTs. Are PFTs a good screening tool for ILD and systemic sclerosis? I'm not going to go through the details because it's going to be covered in Dr. Rahma's talk. But in this study, prospective study, 102 patients with systemic sclerosis, all of them got HRCT and pulmonary function test. Of the patients who had HRCT positive, so all of those circled has ILD based on the HRCT, forced vital capacity was normal, negative, meaning normal, in 62% of the patients. So very high false negative rate, up to 62%. So you're going to miss around 62% if you rely only on pulmonary function test. So that being said, we should do PFT as a baseline, as a reference for your patients, and you should repeat it on the next follow-up visits. The reason why I'm saying that is it's good to have a numbers as a baseline. For example, if I have a patient who presented forced vital capacity of 94% at baseline, who's asymptomatic, the year after I repeat the PFT and his vital capacity is 85%. Even if the patient is asymptomatic, probably I'm going to do a HRCT because the forced vital capacity is still normal, above 80, but because there is a trend toward decline, definitely I'm going to proceed with doing an HRCT. So are chest X-ray a good screening tool for ILD in systemic sclerosis patients? I already see heads, no? Good. So in this study, 180 patients with ILD based on HRCT confirmed, and then they reviewed the chest X-ray for the previous 12 months. And actually, they missed around 63% of the patients. So 63% reported as normal chest X-ray. So definitely do not rely on chest X-ray for screening because you're going to miss significant number of your patients. So what's the best modality to screen for ILD in systemic sclerosis patients? As I mentioned earlier, you need a test that's highly sensitive, highly specific, and HRCT for the diagnosis of ILD has a sensitivity and specificity of 95 to 100%. So it's going to be your best screening test. However, some might be concerned about the risk of radiation exposure, but as I showed you in the previous slides, with the outcomes, the mortality, morbidity associated with that, the benefits would likely outweigh the risk from the exposure to radiation. An important point in the CT scan for my colleagues in rheumatology is when you do the CT scan. So if I show you this image, you're going to say that this patient has interstitial lung disease because they have abnormalities in their dependent lung zone. However, when you prone the patients, so you flip the patients, all of those changes actually disappear. So this patient does not have interstitial lung disease. It's only dependent changes that we can see with HRCT, especially in obese patients. However, on the other hand, patients who have supine abnormality, when you flip them and the abnormality persists there, that means that this is an actually interstitial lung disease and it's not dependent changes. So it's important to do supine and prone images to avoid misdiagnosis of interstitial lung disease. So what does the guideline and consensus statement say? This paper was published back in 2020 for expert consensus statement for the screening of interstitial lung disease. So they recommend screening all patients with HRCT and PFT at baseline, and they put the recommendation to do HRCT should be determined by the clinician, how frequent to repeat that, and they recommend to repeat PFT on a regular basis. And then we have the most recent ACR summary guidelines. The full manuscript has not been published yet, but if you look at it, if you have a patient with increased risk of interstitial lung disease and systemic sclerosis is one of those patient population, they recommend to do a PFT and high resolution CT scan. If you have your ILD diagnosed, then they're going to be treated and being monitored. If no, they recommend rescreening on high risk patients. But what's happening in clinical practice actually? So this is a survey of 200 physicians from Scleroderma Referral Center, different parts of the world, US, Canada, North America, Australia, Europe, and actually only 64% do HRCT at baseline. 30% do not do HRCT at baseline, they do it based on clinical judgment. And 4% actually do not do any HRCT at baseline. So, زي ما قالت رحمة الجوابين كلهم C. Okay. So, moving on. Now we screen the patient. We know the best test to screen at baseline is HRCT. So your first screening was negative. How long should you screen after a negative baseline HRCT? And that's a difficult question because we have data about who is at risk of developing ILD, who is at risk of progressing, but we don't have any data about the patient who is negative HRCT at the first time, what to do next with those patients. Do I repeat CT scan after 3, 4, 5, 6 years? And to answer these questions, I would like you I found this study is very interesting. It was published as an abstract in the ACR last Congress. So 11,000 patients from the EU STAR data set who had an available ILD status at baseline and at follow-up. So the patient who did not have ILD at baseline was 5,000 patients, and 20% of them developed ILD. Okay? What's important here is actually the timeline. Up to 10 years follow-up, you can see that the incidence of ILD is almost steady during the course disease. We used to thought that it's probably the first few years, but actually it's up to 10 years. They have a stable incidence rate of developing ILD. So probably you should screen your patients along the disease course. But the problem is, am I going to do CT scan every year? That's a big issue, right? If you do it CT scan 3, 4, 5, 6 years, that's a lot of radiation exposure to your patients. So you need that tool to help you and guide you to order CT scan or not to order a CT scan. And this is where it comes the ILD risk score, and it's going to be published soon. So the ILD risk score came out with an idea of analyzing the patient with systemic sclerosis. So 6 referral centers in Europe, they did multiple variable analysis with a target of sensitivity of 85%. And when they did that, they chose those factors as for the scoring system. So they chose digital ulcer, age, systemic sclerosis antibody, forced vital capacity percent predicted, and DLCO percent predicted. And then they apply this to the validation cohort using an ILD risk score of more than 0.3%. And they had a good sensitivity up to 85%. So at baseline, the derivation cohort and the validation cohort met the sensitivity of 85% using an ILD risk score of 0.3. So they also tested it in the follow-up visits. So they had 820 patients for the follow-up visit who did not have ILD at baseline. And then they had almost 2,000 visits. And as you can see, with ILD risk score of more than 0.3, more patients had ILD. And less patients with ILD risk score less than 0.3 had ILD. So those patient populations are probably the patients I'm going to order CT scan on regular basis because they're at high risk of developing ILD. So with that, I conclude my talk with the take-home messages. So ILD is a common complication of systemic sclerosis, and it's a leading cause of death for systemic sclerosis. And as I showed you, screening is very important because it's common disease, high mortality. We have treatment available now, and there is a better outcomes with the treatment. You should screen all of your patients with HRCT, supine and prone, and pulmonary function test at baseline, and then reassess the screening based on your ILD risk score, patient risk factors. Do they need a repeat HRCT or no? Thank you.